Welcome to the final explainer in our six-part series. Today, we're bringing together the most critical paradigm shifts and universally applicable finish lines in vestibular schwannoma management. We're going to be unpacking the data on neurofibromatosis type 2, the unique complexities of bilateral tumors, and those absolutely essential frameworks for vestibular rehabilitation and quality of life monitoring. As always, this clinical explainer is drawn directly from the comprehensive, evidence-based literature review provided by Australian dizziness clinics. This really is the culmination of our deep dive into the clinical rigor and evidence-based practices that guide neuro-ophthalmologists today. It's honestly fascinating to see how the literature systematically shapes these incredibly complex clinical pathways. Here's our clinical pathway for today. We'll start with the unique challenges of NF2, explore targeted medical management, and then we'll conclude with the universal necessity of vestibular rehabilitation and quality of life monitoring. Okay, let's jump right in, because we need to address a fundamental shift in clinical philosophy straight away. In sporadic, unilateral cases, the aim is typically to control or eliminate the tumor. But with NF2, the paramount goal is entirely different. We are aiming to protect the last serviceable ear. That single shift in priority literally recontextualizes every single management decision moving forward. Section 1. The NF2 paradigm shift. Let's dive into exactly why this shift in priority changes everything for neurofibromatosis type 2. Starting with the underlying biology, NF2 is an autosomal dominant syndrome driven by a germline mutation on chromosome 22q12. Now, what this does is essentially cause a loss of function in a tumor suppressor protein called myelin, or schwannomin. Think of myelin as the brakes on cell proliferation. When it's absent, those brakes are gone, allowing these benign that highly destructive Schwann cell-derived neoplasms to grow completely unchecked. Diagnosis heavily relies on the revised Manchester criteria. And while you might have a patient presenting with a unilateral tumor and a first-degree family history, the absolute hallmark of NF2 is bilateral vestibular schwannomas. In fact, finding bilateral tumors is entirely sufficient to establish an NF2 diagnosis all on its own. This perfectly illustrates our diagnostic gold standard, the gadolinium-enhanced MRI. When NF2 is suspected, we've got to carefully evaluate the differential tumor burden in both cerebellopontine angles. The focus isn't just on the size of the mass, it's about constantly tracking the growth trajectory and understanding how it's threatening adjacent structures on both sides simultaneously. But keep in mind, the diagnosis often means looking beyond the MRI. Any patient presenting with bilateral VS or unilateral VS when they're under 30 years old needs a full cutaneous examination. We're looking for skin features like café au lait spots. Even though they're fewer in number than what you'd see in NF1, finding them alongside early onset tumors makes formal genetic screening and counseling absolutely mandatory. Section 2. Managing bilateral schwannomas. So how exactly do we tackle bilateral tumors when standard surgical intervention carries the massive risk of complete bilateral deafness? Well, because traditional microsurgery and stereotactic radiosurgery carry such huge risks to whatever hearing the patient has left, the literature increasingly points us toward targeted medical therapies. Bevacizumab, an anti-VEGF monoclonal antibody, has really emerged as a fascinating frontline option. And for those cases that do unfortunately progress to profound bilateral deafness, that's where auditory brainstem implants come in. Crucially, though, every single one of these complex decisions must be made within a specialized multidisciplinary team. There is no working in silos here. Now, what stands out as a genuine game changer in the data is the response to bevacizumab. It demonstrates hearing improvement or stabilization in roughly 40 to 60% of NF2 patients with progressive tumors. That is a massive deal. It's remarkable to see a systemic medical option actually preserving function and potentially even shrinking tumors in situations where surgery might have destroyed that remaining hearing. But what happens if the auditory nerve is completely compromised? This is where auditory brainstem implants step in. An ABI entirely bypasses the absent or non-functional auditory nerve to deliver electrical stimulation directly to the cochlear nucleus in the brainstem. Now, performance definitely varies. Most patients achieve environmental sound awareness rather than open-set speech, but even so, an ABI significantly boasts the quality of life and communication capabilities for profoundly deaf NF2 patients. Section 3. Vestibular rehabilitation pathways.
Whether we're managing sporadic VS or complex NF2 cases, vestibular rehabilitation is the crucial mechanism that actually sustains patient outcomes and closes the loop on treatment. The literature here couldn't be clearer. Generic physical therapy just doesn't cut it. Highly structured vestibular rehab delivered by a specialized physiotherapist significantly outperforms no intervention. And perhaps more importantly, we shouldn't wait for our patients to fall or complain of severe dizziness. Referrals need to be proactive. Ideally, we should initiate them before the surgical or radiation intervention even happens, so we can optimize central compensation right out of the gate. So let's trace the actual protocol outlined in the data, because it is highly structured. It starts with foundational gaze stabilization exercises. Think VOR X1 and X2 at progressively higher speeds. Once that foundation is locked in, the protocol shifts into visual motion habituation to tackle visually induced dizziness. Then, patients graduate to balance retraining and finally complex dual-task functional gait progression. The goal is to get them back to work and daily life safely. To measure if this rehab is actually working, we track the Dizziness Handicap Inventory, or DHI. In this specific clinical context, an 18-point improvement on the DHI represents the minimum clinically important difference. That 18-point drop is the exact threshold where a patient's real-world disability is tangibly, meaningfully reduced. And the data strongly supports this approach. Between 60 to 80% of patients will successfully hit that critical 18-point milestone if they adhere to a structured vestibular rehabilitation program. It's an incredible reminder that while we can't always restore a physically damaged nerve, the brain can absolutely be trained to compensate effectively and restore a huge amount of function. Section 4. Quality of life domains. This brings us to the ultimate metric of clinical success. Because at the end of the day, it's not just about what the MRI scan shows. It's about how we systematically monitor and support the patient's holistic quality of life. The guidelines are very clear here. To avoid missing hidden impairments, all 4 distinct quality of life domains must be tracked concurrently. That means we're measuring vestibular handicap with the DHI, tracking hearing function with audiometry, quantifying tinnitus severity using the THI, and crucially, assessing psychological well-being and balance using validated tools like the HADS and the Berg Balance Scale. Every single one of these domains heavily impacts our patient's daily reality. It's so vital to look for hidden comorbidities. Tinnitus, for instance, is present in up to 80% of cases and requires very specific, structured counseling. But here is perhaps the most surprising finding in the literature. Pre-treatment anxiety and the psychological burden of living with a brain tumor are actually stronger predictors of long-term disability than the specific tumor treatment modality you choose. Let that sink in. Central compensation and psychological resilience truly dominate the functional outcome. Because this is all so complex, the clinical finish line is strictly defined. Patients are only considered ready for discharge from specialized rehabilitation once their DHI drops below 36, they've completely regained functional independence in their daily lives, and a robust home maintenance program is firmly established. All right, let's quickly summarize our key takeaways from this final module. Number 1, NF2 mandates a hearing preservation first philosophy. It is a completely different ballgame compared to sporadic VS. Number 2, medical therapies like bevacizumab are critical tools for progressive bilateral tumors. Number 3, structured vestibular rehabilitation is highly effective, driving major functional DHI improvement in 60 to 80% of patients. And finally, active multi-domain quality of life monitoring is the true measure of clinical success. As we wrap up this explainer series, I want to leave you with a final provocative thought. If the data clearly shows that pre-treatment anxiety and tinnitus predict long-term disability more powerfully than the surgery or radiation itself, are we intervening early enough in our patients' psychological care? Or is our field still focusing a bit too much on the scan and not quite enough on the mind processing it? Thank you for watching this series. To explore more similar topics regarding dizziness, vertigo, and imbalance, and to access clinician materials, please visit www.australiandizzinessclinics.com. Please subscribe and rate this series.